So let's kind of resume. Well, let me start out with first meta-analysis. I thought it'd be good just to briefly summarize the couple of meta-analyses that have been done looking at adherence promotion studies in pediatrics. This first one was done by Kahana et al. 2008. They looked at 70 adherence promotion studies and then weighted by sample size, which is the way you calculate effect sizes. Everybody knows that if you give more weight to smaller numbers, it's not fair, and you got to balance that out. They were in the small range, so the D was 0.34. However, there was significant heterogeneity across the adherence outcomes. Therefore, the authors examined potential moderators of the effect sizes. And here's what they found that I think are interesting. Behavioral strategies had a medium effect size. They were higher. Multi-component was right up there. Psychosocial, as you can see, education was small. Technology base was small. I think we'll talk about the reason for that and the technology also. The second meta-analysis was done by Graves et al., which is a former student of ours at Kansas. And then Dr. Graves looked at 71 studies, but she also looked at group and single subject design studies. And the mean effect size weighed by sample size for group designs was 0.58, which is in the median range. For group designs, the moderators of effect sizes, where there were higher effect sizes for studies using a weightless control, D 1.09 versus alternative treatment. So when you're testing an intervention, usually the first step is to see if it is better than standard care alone, which is essentially what you're doing with the weightless control design. And you'd want to do that first because, you know, if the intervention doesn't work any better than what everybody already does, who cares, right? So if it does, then the next step is to say, is there some alternative treatment that you can compare it to, or an attention placebo type treatment, which has some elements of your intervention, but not what you might consider the active elements of your intervention. Much more stringent test, and as you can see, the effect size is much lower when you use that kind of design. Let me just say, additionally, the advantage of the weightless control is then you can offer the intervention to the weightless control after the follow-up period is done. So you've got baseline, you've got the intervention doing their thing, weightless controls waiting, and then you do a post-intervention, post-waitlist test to compare the two groups. Then you give the treatment to the weightless control design, and then they get a post-test. So you get a pre-post on both groups, which is nice, so you can take advantage of that data. So it's kind of a nice design to use when you're first testing programs. The mean effect size weighted by sample size for single subject designs is 1.53, which is very large. And these were very homogeneous. The reason for that, I think, is because single subject designs, essentially, you really have to convince yourself, number one, and your colleagues that you've had a really significant effect. You have to see the obvious change in adherence on visually graphed data. Normally not statistically analyzed, although in some cases you can. And in some cases it agrees with the visual inspection, in some cases it doesn't. But I think the effect sizes were higher here because the studies that are published really show a very clear effect. That's my guess. So the other thing that Graves did was to look at health outcomes, and 31 of the studies reported health outcomes like A1C, disease activity, healthcare utilization, subjective measures, quality of life, for example. And the mean D here was 0.40, which is small to medium. And the effect sizes were higher for hemoglobin, for A1C, well, hemoglobin A1C, I was right. And then pulmonary function testing, disease activity, and healthcare utilization versus not so good effects on BMI and quality of life. So in the title, I suggested to you that I was going to talk about prevention models. And it's taken me this long to get to this, but here it is. So in 2000, I proposed that we should define something called clinically significant non-adherence. And what I meant by that, and this is the definition, inconsistencies in following a particular regimen that may result in a compromised health and well-being. Much to my chagrin, the term hasn't caught on. So I'd appreciate it if anyone watching this or listening would promulgate this terminology. I thought it was pretty good, actually, but who knows? But the idea there is, when do you consider non-adherence a problem? When do you bother with it? Why not leave people alone if they're doing well enough? Well, you probably should. So primary would focus on those people not yet exhibiting clinically significant non-adherence. That would be truly prevention. That would be things in the clinic that would be routine for all patients and families, given the same educational information, strategies, that would help them not get into trouble, basically, right? And then secondary would focus on patients for whom clinically significant non-adherence has been identified early on in the disease course or has yet to compromise health and well-being. So in other words, it's starting to look like it's going to be a problem. Adherence is going to have some effects on outcome. And then the obvious one is patients who usually get referred to psychologists like me. And those are people that the doctors are saying, I definitely think that non-adherence is interfering with this patient's progress. So if you took a primary prevention approach, what sort of things would you do? Well, you'd educate people about their medical regimen importance. You'd have organizational strategies like trying to simplify their regimens. You'd have monitoring of adherence by the providers and the parents, some basic strategies that I believe can be implemented by primary health care providers, nurses and physicians, for example. And most of the time, I think it's going to be nurses. And then secondary would be more frequent, so you kind of ratchet up a little bit the interventions where there's more frequent monitoring of adherence by patient and parents, positive social reinforcement, and general discipline strategies for timeout. Timeout, for example, for younger kids. And I believe primary health care providers can do these things, nurses, for example. There is a protocol that I talked about already for non-adherence, to not taking medications. I think there's no problem that a nurse can learn how to do that and go over it with a family. So that if a 3 or 4-year-old comes into the arthritis clinic and says, Joey won't take his pill, but yet he can swallow it, no problems with that, then the nurse says, hey, here's a protocol I want to show you on how you put him in timeout if he refuses to do it. I think nurses can do that. And I think physicians probably won't do it. They're smart enough to do it. They don't have the time to do it. They also don't have much of the temperament to do it. So I think nurses are the ones that should do it. So tertiary would really be pediatric psychologists. That's our bread and butter. And those are things like token systems, written contracts, self-management training, and psychotherapies that are done in like family system-based psychotherapies, Tim Wysocki's group at Moores and other people, that are much more complicated. They require the skills of people that have been trained to do therapy, like clinical psychologists, right? So that's our job, but I think a lot of it with this primary and secondary, we can give away our technology to other people who are routinely part of clinical care for chronically ill kids. There's not many places, I can tell you, in rheumatology clinics where there's a psychologist like me, in pediatric rheumatology. It's very unusual. I'm one of maybe 2 or 3 in the country. So it's not very feasible to have a psychologist in that clinic. But we can develop programs and we can help train nurses in particular, and maybe occupational therapists, physical therapists, to implement these kind of interventions. And so that's what I meant by primary, secondary type thing. That makes sense? Any questions so far on that? I'm halting because I ate a nice lunch. Go ahead. Absolutely. Particularly the school nurse. I really see a role for the school nurse in that situation. And we've had that happen before where, we've had kids have to take their medicine down at the nurse's station. They've monitored, or the nurse has been trained to do pulmonary function testing or some other function that we needed to help take care of a kid. No question about it. When I was on the asthma educator, what do they call us, faculty. So there were a bunch of us from the American Lung Association trained a bunch of us, and I was a psychologist, we had a pulmonologist, we had a school nurse, and all of us were trained to work together in these workshops to train school nurses and other people on how you can help children with asthma, how you can be involved in the school setting. So I definitely think the school does have a role. And even teachers. But nurses, I think. Good? I'm going to go to eHealth. So what's eHealth? eHealth interventions are applications of technology that seek to improve a client's understanding of health information or use technology as a surrogate for the for the clinician in treatment delivery. So modes of delivery. Well, programs are designed to be web-based. 77% of U.S. population have access to the internet. I think that figure is higher than that since I did that. I think it's getting closer to the 80s or 90s. But people can do CD-ROM programs if they don't have access to the internet, and we have done programs with CD-ROMs. There are organizational websites that have a lot of really good information that we as pediatric psychologists need to give families an idea of what are the legitimate sources of information on the web. And this particular one, the Juvenile Arthritis Alliance on the Arthritis Foundation website, is excellent. There are some computer games that teach people about their diseases in children and also hook up children to communicate with each other who have cancer in the hospital. Starbright Foundation in in California has done a very nice job, and Steven Spielberg and his group has been involved with this organization. I mentioned before that some of their programs, like they have one on asthma, and Cuba Goody Jr. is the primary protagonist in the game, and they're after these evil people and all this stuff, and it's very well done. There are all these Hollywood people in there, Diane Sawyer, of course Spielberg knows everybody, and it's really slick and it's well done, and you identify triggers. The problem is it's all educational. There's nothing in there about how you adhere to your treatment. What are some good strategies? It's educational and it's well done. So if you wanted to use it for educational purposes, it would be excellent. And the only study that ever looked at the Starbright ones was by Dr. Alexander Quittner, and she looked at the CF program. And what did they find? Well, they found that parents that looked at the program got knowledge gains. I'm not remember about the kids, if they measured the kids' knowledge. Maybe they did. Knowledge gains. Okay, but did they get any improvements in adherence? Well, number one, I don't even know if they looked at it, but if they did, they didn't get any. So, because we all know that education is necessary but not sufficient, right? I keep doing that. PDAs, forget them. They're going out of style. I had to throw mine away. I didn't even get to use it for very long. That's the thing about now. My iPad is iPad 2. Well, my wife's got iPad 3, right? Isn't 4 coming out pretty soon? Yeah. It's just, every time you turn around, your phone's out of date and all that stuff. But anyway, there's some phone applications that deliver content or prompts to engage in healthy behaviors. For example, I'm working with Nikki Nolan, one of our public preventive medicine faculty, and she recently published a paper looking at, she's working with teenage African-American young ladies who are overweight and trying to prompt fruit and vegetable consumption. And it's a phone-based program, and when the kids do the program and respond to the prompts and all that stuff, they get to download an iTunes song. It's what? Huh? That's, oh, it's smart. Okay, good. Well, I'll tell her. You guys said that. She's smart. That's kind of neat. Have any of you heard of the PTS Coach? It's actually, it's called the PTS Manager. Let me make sure I'm telling you the right thing. Oh yeah, what's that one about?
I think it was originally developed for transplant patients, but it's totally free, and patients can create an account and they can put all of their meds and all the dosage. It has pictures of the pills.
Perfect.
You can create several different kinds of med sheets and med tracking sheets, and then what they could do with it is you can get it on your smartphone too, and then when you bring it into the physician's visit, they could change their meds right there and the dosages.
So we're talking about post-transplant?
Yeah, but I actually think they have so many medications in there that I think just about anybody could use it.
And it's called MyMed.
MyMedSchedule, all one word, .com.
Very good, thank you. Marvelous, that's great. Well, thank you so much for that. PTS Coach is the name of this program, and it was developed by Veterans Affairs. The thing I like about it, it's a self-contained program, and the only reason I'm telling you about this is not because of PTSD, but because I think we can do this with adherence. If not part of a web-based thing, or the entire thing being web-based, phone app-based. So what they do is they have a thing on Learn, which gives you information about what PTSD is. Learn about PTSD. What is PTSD, for example? Tap to listen.
Post-traumatic stress disorder, or PTSD, is an anxiety disorder caused by traumatic events, such as combat, disasters, terrorism, serious accidents, or physical or sexual assault.
So then, okay, so that's the section on learn about PTSD. Here's the one I really like, managing symptoms, let's say worried and anxious. They have a little distress meter here. So you mark your, because you guys are stressing me out, I guess. Okay, here's progressive relaxation exercise.
Please note that if you have injuries such as back pain or a knee injury, you should avoid tensing muscles that might affect that injury. To begin, close your eyes and take a deep breath into your belly. Then exhale with a sigh. Again, take a deep breath and imagine clean air going down your
So the idea of this app is that soldiers coming back from Iran and Iraq can use this as a totally self-sufficient program. It also has some resources on there and phone numbers you can call to get help, and what psychologists do and what psychiatrists do and all that kind of stuff. And we talked to the people that developed it. They're actually civilian people working for the military, and they're developing these apps, and they've been very helpful in giving us advice on how to do this in the health arena. So we're looking at this as either an adjunct, like I said, to a web-based program, or actually having the whole thing on there. Because I could imagine, like, say a parent was going through a module and it said about prompting your child's medication, and then we had them download this My Medication thing. That would be great. Okay, so that's the iPhone stuff. I don't want to talk about telehealth because it's a whole thing on its own. Yeah, have any of you done telehealth, telemedicine visits? And they're wonderful. I don't do them, but we do. We have a lot of faculty who have outreach way out in western Kansas, and then they do all their follow-up on telemedicine. And we very well could do that with interventions, even if we had a web-based intervention. And we built into those some Skype contacts or telemedicine contacts with our patients. We'd have to be careful about it being, secure and all that, but I think that those technologies can be used. Some of the programs that you find are self-sufficient, and they need very little contact with clinicians or researchers, except for prompts to enter the data and complete the modules. The one that I'm going to show you, that's the way it is. Some are more limited adjuncts to contacts with clinicians to provide additional reminders or information, like email contacts between clinic visits. Advantages of eHealth: they can be highly structured, standardized, enhancing treatment fidelity. You know what you're delivering. You're delivering in a consistent fashion across sites. You don't have to worry about fidelity. They also can be tailored to specific barriers or concerns. They're cost-effective and accessible. Parents miss less work, children less school, reduced travel and visits. Parents and kids, or particularly the kids, are techno-savvy. You can add these engaging elements: audio, video, animation, music, interactivity, making them more attractive. Data entry and completion. The program modules can be monitored online in real time and generate prompts. We know in our current program when parents go online and when they complete a lesson. And if they've entered the data, if a data is missing, if a part of the data is missing, we can prompt them to fill that in. So there has been a meta-analysis of eHealth interventions in 2010 by Christopher Cushing and Rick Steele. They looked at 33 studies that targeted programs on pediatric diseases and also on health behaviors. 39% of the studies used educational interventions and 20 behavioral. Cohen's D's, and again, these 20, you can see what the small, medium, large is, but weighted by sample size, the mean effect size for all interventions was small, but behavioral interventions, as you can see, was much higher at 0.35, while educational interventions were not significantly different from 0. So that's the problem when you aggregate educational and behavioral. You really pull down the effectiveness of the behavioral. But when you separate it out, you can see that the behavioral interventions are a lot more effective. So the conclusions from the meta-analysis: education is not effective as it targets knowledge, not changes in health behavior. Knowledge alone is not sufficient to produce behavior change. The effectiveness of behavioral interventions mirrors that of face-to-face delivered interventions, which is very important that you have interventions that when you put them in a technology-based format, that they've been shown to be effective face-to-face or in groups, right? And that they're comparable to those face-to-face or group-delivered interventions. Jen Stinson from Toronto Sick Children's, who's a nurse with interest really in pain, looked at internet-based self-management programs for a variety of conditions. She defined self-management as the individual's ability to manage the symptoms, treatment, physical and psychological consequences, and lifestyle changes inherent in living with a chronic illness. So you can see that she's broadened this out to more than just adherence. Adherence being a subset of this. She looked at 9 studies, 8 randomized controlled, 1 quasi-randomized. 7 of the 9 studies showed significant improvements in health outcomes compared to controls. 4 studies focused on asthma found significant decreases in healthcare utilization. So the conclusions from Jen's review was that adherence to internet interventions is problematic like it is with others. The dropout rate, when she looked at it, was average of 14% with a range of 0 to 28, which is comparable to the 20% rate found in cognitive behavioral studies with chronically ill children. So this student of mine, Cindy Carlson, did this review and it came out in 2009. We were surprised that nobody had really looked at attrition rates across these studies. And we attempted to find the different kinds of attrition because when you recruit somebody in the beginning and they never get randomized, that attrition is different than someone who's completed the intervention and then drops out. So we had various definitions for attrition in that paper if you want to look at it. We need higher quality studies with larger sample sizes. Can we say that until we absolutely get sick at our stomachs? How many times have we said that? So how are we going to get that? How are we going to get this? Larger samples. Multi-site. We've got to convince NIH, number one, to give us money for a multi-site study, like they do in drug trials. You look at some of these drug trials, there's like 15,000 people's names on the paper because there's like 14, 15, 20 sites. We need to develop a consensus on the steps to take in developing and testing internet interventions to ensure usability and feasibility, a little bit like what we went over earlier when I talked to the people at Cincinnati. Greater uniformity across assessment intervals and longer ones to evaluate long-term effects, and elucidating the mechanisms and actions of interventions, what works. Some of the barriers to e-health are that some families may not be so technically savvy. Low ESCS families may not have computers or access to internet at the home. What we have done was we've lend out computers that are locked in only to the website that we have our program, and we pay for internet access as long as they're in the study. You run the risk of losing a computer, which is why I would suggest you buy the cheapest one you can, which is what we did. Programs are expensive to develop, implement, and maintain. Quality control is critical with content reviewed by informed professionals. Requires the input of many professionals, doctors, psychologists, computer and web programs, web designers, graphic artists, database developers, and health informatics people. So it takes a real team to do it. There's HIPAA compliance issues. When you're trying to get people to enter data online, you have to be very careful with that. Encryption of email, other type of online information, protecting privacy, confidentiality. The lack of professional monitoring of patient or family chat rooms, Twitter, Facebook, and email contacts need at least a disclaimer that information obtained in these ways should be discussed with your clinician. So anytime we put a program up, for example, Headstrong, which is the one we use for kids with migraine headaches, we always say this is not a substitute for medical care. You should not stop any medical care that you're currently receiving, and you should inform your doctor that you're wanting to use this program. Most of the time, we have not given the program unless it's been given through the patient's doctor, although that may change pretty soon. There is a lack of personal contact with clinicians and possible unexpected negative outcomes from interventions. We don't know a whole lot about that, but we need to look for it. So future research and clinical practice, e-health are promising, need to be adapted and validated face-to-face, need a consensus on steps for developing and testing the interventions, identify the problem, ascertain the effectiveness of established treatments, operationalize the treatment completely, look at the legal and ethical issues, transform the elements using engaging components, personalize, tailor as much, construct a program and do initial focus groups to get feedback, and then finalize and do the pilot study. Continued with this, evaluate interventions as usual versus treatment as usual, then go to attention placebo. Multiple outcomes, quantitative like adherence, qualitative user ratings of acceptability and feasibility. You can have very effective interventions that people don't think are feasible and they don't want to use them. Outcomes measured over longer periods, measure adherence to e-health interventions. How do you know people have accessed the program? Is there a way of telling whether they've done the lessons or not? And yes, there is. Facilitate collaboration across multiple sites. Start to incorporate well-validated e-health interventions into routine clinical practice as an adjunct to good clinical care. And I really think we can do all those things. As far as collaboration goes, I think I may have asked some of you, how many are members of Division 54, Pediatric Psychology? Okay. So you may know I'm going to be president next year, and one of my initiatives is e-health interventions. And one of the things that I want to have a task force. This all has to go through the board and approved and everything. One of the things I want them to look at is how we can facilitate collaborations and multi-site interventions. And what I think what we can do, because we have SIGs, we have special interest groups in different areas, that those special interest groups can develop technology-based interventions, obesity and adherence and pain and whatever have been developed in some of those areas already. And that the SIGs would be a way of really facilitating multi-site studies. That people would present to their SIG group and say, I've got an idea for a study. Would people like to sign on to this study? Now you'd have to have, I think you'd have to probably have a subcommittee in your SIG that would be the people that looked at all the ones that were submitted to make sure that they're of a decent quality, you know, and they should go forward, and then look at who would like to participate in that. So I'd like to, I think that's one way of doing this business of collaborating. So I'm hoping we'll do that. Adherence Strong is the fourth web-based program that we've developed. The previous three were pain management ones. This is the first attempt to do an adherence-related intervention on the web. It's an NIH-funded trial, waitlist control, web-based program, parents of children. There's a bimodal distribution of when children get diagnosed with juvenile arthritis. This is the lower age range, and we decided to focus this program just on the parents. Okay. And here are my co-investigators: Carol Lindsley, rheumatologist; Katrina, my graduate student, and the OT study coordinator. It teaches parents strategies for enhancing adherence to prescribed medications for JA over a 4-week period. And then we have electronic and parent-related adherence measures as well as measures of quality of life. So, okay. So what you'll see is that there are a series of lessons here. There's one lesson week. 1, 2, 3, 4. Now the reason we can click on any of these is that I've gone through them all and took the quizzes. If you were a new parent and you just got your login and you went to week 1, lesson A, what is juvenile arthritis, you can't go any further than that until you get that done. Okay? So that's a way of getting parents to go through it sequentially. What do you want me to click on? Okay. Now you notice that there are words here, right? No, I don't. So there's all these words down here. But you can also do this if you want a little flash going.
Week 2, Lesson D, Positive Feedback for Adherence. Importance of encouragement. Following a treatment program for a chronic disease like arthritis is not easy. Everyone needs some encouragement, and this is particularly true for children living with a chronic disease. It is important that you give your child positive feedback when the treatment program is being followed consistently. This is most effective when done immediately after your child does what was asked. Praise from parents is one of the most powerful rewards for children. Praise for older children. Praise is not just for younger children. As they grow older, children still like to hear positive comments. You may choose to allow your child to earn tokens. Week 2, Lesson D, have what is in the picture. Difference between reward and bribe. You might be saying, well, isn't this like bribing my child to do something that is supposed to be done anyway? To bribe someone means to offer the person something good for doing something illegal or immoral. To reward your child for following the treatment program is not bribery. Even though your child should know what to do and do it because it can help, children don't often reason this way. They don't see the long-term consequences of their actions or lack of action. As a parent, you have to make sure your child takes medications and does other things to control their arthritis to avoid long-term damage to joints.
So you get whatever it is. In this case, an enhancement, but it could be something else. Little kids really like that. We got that business about bribery is something that comes up often, so I do give parents that definition. It's something that politicians engage in, not parents. We're not talking about parents. We're not talking about politicians, but parents. So here are the quizzes. Oddly enough, Mike Rapoff got all three of them right. But, they're pretty simple quizzes. Not really meant to trip people up or anything. Let's see. Let me go back to. Okay. I did want to show you the discipline one. So we've got that here.
Disciplining your child. Importance of discipline. In spite of your best efforts to reward cooperation and ignore minor complaints, your child may refuse to cooperate at times. When this happens, you have few options but to discipline your child. This is never easy for parents. It is particularly hard for parents of children with a chronic disease like arthritis. No parent wants to add more negatives to a child's life, especially when the child has to cope with arthritis pain and activity limitations. The best thing you can do is to treat your child with arthritis like any other child. All children need to develop self-discipline, whether they have arthritis or not. It may actually be more important for a child with a chronic disease like arthritis. Your child has to do more than children without arthritis, like take medications and do special exercises. You're to take medications. Using Timeout. Using Timeout for medical non-adherence. Guidelines for parents. Timeout is a discipline strategy to reduce
Let me just stop there for a second. The point about that I say to parents about discipline, that discipline means more than just punishment, like timeout, that you have the necessary skills and motivation to do the things you need to do. And children with chronic illnesses have to do all the things all the other children have to. And yet they have to do the additional things to take care of their illness, so they need to be more disciplined than most children. That's why it's really important that from the beginning that you discipline. You have very clear expectations for your child. You reinforce them when they meet those expectations, and that you use timeout and things like that for refusing to do things. And your child's going to be just required to deal with a lot more things and be more self-disciplined. Everybody in this room are advanced in their education, and you folks got here because you're pretty self-disciplined, and you got that from somewhere. It didn't just come out of the blue. And I suspect there were a lot of people in your life that helped you to be disciplined. When I got to graduate school, and I was sitting around in my first graduate school class, and there were a lot of older graduate students there, and they were all talking about some particular topic, and I thought, my gosh, these people are really smart. But it occurred to me that we were selected for being smart. That all of us in that room had performed pretty well to get to that point. And the kids with chronic illness have to have more of that discipline. And that seems to resonate with parents. They seem to understand that point pretty well, I think. One thing I did want to show you that I'm not happy with the quality of this. I must tell you ahead of time, but just the way it is.
Week 3 lesson to take medications.
Okay, so the timeout, what we had done is I went to the home of a parent whose child actually has arthritis, and with my Sony digital camera, took this demonstration of timeout that was conducted by our occupational therapist. Now, the quality of it isn't as good as what I saw in my digital camera, because when they put them into these programs, they compress it. But I think the next time we do this, I'm going to take somebody's suggestions and actually link it to a YouTube site so parents can see the better quality of it. But I think you'll get an idea of what.
Okay, Heather, we're going to talk about discipline today, okay? And we're going to talk about occasionally in medicine, I don't think this would happen hardly ever, very often, but occasionally if your mom asks you to do something and you don't listen and don't do it, okay, we're going to talk about what she can do then. So we're going to talk about timeout. So for example, if it's time to give medicine or medication, or put your clothes away, or pick up your room, or go to bed, something your mom asks you to do and you don't choose to do it at that time, then you may want to use timeout so that you can accomplish it. So there's 2 rules for timeout, okay? And the first rule is your mom's going to get a chair, she's going to prepare the space and put it someplace where you can't see TV, you can't read a book, you can't do anything fun, okay? It's got to be kind of boring. And then she's going to ask you, like say it's time to take your medicine in the morning, she's going to ask you to take your medicine, and we're just going to pretend that you say no and walk away, okay? So if you would do that, then your mom might ask you again, Madison, it's time to take your medicine. Do you want to take your medicine? And if you say no again, then she may say it's time to go to timeout. So the first rule about timeout is she's going to help you walk to the chair, or you may walk to the chair, and you need to sit in the chair and you need to sit quietly. And like that kitchen timer we talked about, then she'll set the timer for 5 minutes, because how old are you? 5, okay. So she'll set the timer for 5 minutes, and then you're going to sit in the chair, and one rule is that you need to be quiet.
You get the idea. So this is a very cooperative child, by the way. And so she did go through the whole timeout demonstration. She sat quietly in the corner. She understood that we were just play acting and that she wasn't in trouble. And Mom did a great job in doing the timeout. And so other parents can look at this and see this is a mom, real live mom with a child that really does have arthritis. And this is the way that you can do timeout with them. So, so there's some practical things in there like that on the program. And then, as you can see, we also have assessing barriers. And this part, we can show you a little bit more about that. But also, we thought it was really important to put in communication and stress management. That parents of chronically ill kids need to learn how to communicate with their kids, and also use relaxation, other positive thinking, and time management strategies to really help the parent when they feel really stressed. So that's the program so far. We're doing it at about 3 different sites at this point. I don't have any data to report, but hopefully in the next year we will. And the next step would be to develop these interventions for young children with arthritis that are going to look very different than this. They're going to be much more jazzier. As you can see, this is very didactic. We don't want that with kids. We want it to be much more interactive, so we'll do that. And then we'll do the one for teenagers. And then maybe simultaneously we'll also be working on an asthma one with my colleague Christina Duncan in Virginia. So there's any number of these. You can do Adherence Strong for JA. You can do Adherence Strong for asthma. Adherence Strong for cystic fibrosis. Adherence Strong for whatever. You could do it. And the format we plan on, at least with the kids, will be the same. It'll be that educational piece where they need to know what they have, and how they were diagnosed, why they're being treated, and then the strategies for how do you keep yourself on track in following the treatment. Anybody have any questions about Adherence Strong at this point?
Aside from, I have a question. You mentioned sort of that you can collect data, obviously, about whether or not they access specific links and things. Aside from that, is there other data that you're collecting through the website, through the program?
No, they are using the adherence measure as the medication event monitoring system. They do that for 2 weeks prior to the intervention, and then they do it for 2 weeks afterwards. And then they do also the PEDS quality of life measure before and after. We don't have it set up to do, well, the MEMS part, you wouldn't have it set up. You can do online downloading of data from the patient's home. A little more expensive. We've opted to just have them mail it back and download it ourselves. It's an R21 grant, so it was kind of small, and we didn't have enough money, basically, to do it. We have done quality of life measures online, and they're relatively easy to put online. The thing you have to have is a server company that would put it on there for you and set it up. And you can set it up so that it goes directly into an Excel or database of your choice, so that you can analyze the data automatically too. Our statistician loves that. We can get that done. So, and he was involved in meeting with the IT people who set up another study that we had. We did have online data collection, and I would encourage you to have your statistician involved in that discussion, because they often want the data in a certain format, and you want to make sure that the IT people can, from the online entry, can translate that directly into an Excel sheet or whatever, spreadsheet. Yeah, it's pretty nifty when you can do it online. It's kind of a much better way of doing it. Okay. Anything else about Adherence Strong? No? Yes?
Just in general, while we're speaking about apps, I know there was a lot of chatter on the listservs about different apps for different things.
Yes.
A few months ago. Was there ever a list compiled? I can't remember whether that happened. Like, is that one of the resources on the Division 54 website?
It's a good question. I don't believe they did do that. I think that was just a chatting going on the website. What I would think should happen is probably the different SIGs should, if they have apps related to their topic, like there's a lot of obesity-related lifestyle ones, and I would think that the obesity SIG might want to get those kind of things together. That may be part of that, the e-health task force that I want to happen. Maybe one of the things they come up with, hey, can we have a further group that looks at all these apps and reviews them for scientific value and publish that in the Journal of Peds Psych or something. So that would be an excellent thing to do. But you're right. I noticed that going back and forth stuff, and I didn't pay attention to a whole lot of them or write them down because I wasn't using those kind of apps. But I know there's been some reviews of lifestyle apps, and some of them are been found to be wanting, but it's mainly been ones that have been done with adults. I saw some reports that said they weren't that swift.
Well, I think when you're in a clinic, when you're in a mostly clinical setting, which are usually more low budget, we were talking a little bit at lunch, measures of adherence, a MEMS cap for a patient who has 15 to 20 medications. A MEMS cap just for one medication would be too expensive for most programs or families. And then if you have 15 to 20 medications, it's unwieldy. One of the questions that we had actually, do they have a Pillbox version of a MEMS cap?
Electronic one, yes.
They do, but I don't want to really push it because I tried it out, and a number of people at Cincinnati tried it out, and there's some really glitches with it. Yeah, boy, it looked like it was going to be a wonderful thing because we were looking at a lot of kids who had a lot of different medicines. And part of the problem was the bins were too small. And you know, how many times a week are parents going to refill those bins? The other is that they were inaccurate at times. They didn't record things sometimes. So supposedly the company's working on it. I don't even want to give them any advertisement yet because I think they have a little work to do on their instrument. But there is stuff in the stages of development for that. Yeah, but you're right. It would be ideal because a lot of people don't want to use the MEMS because they don't want to give up their medication Pillbox. So if there was an electronic one that also beeped when they needed to take medicine, that'd be marvelous.
Sort of like along those lines, I think many of us struggle in the balance, like as researchers and clinicians. And I think one of the things that we really need to figure out is that as researchers, we get our grants and we develop these wonderful web-based applications, but we don't really have a way of sharing that. So, you know, we go to conferences, we see these wonderful programs, and we think, oh, how great would it be to try it out in the clinic. But it's such a long process from the time it's developed to the time that it's published, and then if there's no clinically significant findings in favor of the intervention, then nobody ever sees it. And I've seen, like, I work with children with sickle cell disease, and recently went to our meeting here in South Florida, saw some wonderful web-based pain diary applications where kids were getting money in their bank accounts, like cents, for reporting their pain and adhering to reading. And I was like, oh, that would be great. And then you approach the investigators and they're like, oh, well, you know, we're in this process and it's going to be years before we would even be able to get our hands on something like that. And so now we're trying to figure out how to do that for our clinic, but we have no budget, no current NIH grant that could fund it. And so it's kind of like we're starting from scratch every single time we hear about a wonderful program, and we just have to figure out a way to be able to share those resources.
But I think that's where the apps come in. While we're waiting for the development of the evidence-based, then you at least have the apps, if we can identify them, to fill in the gap. Because I was amazed when we started looking. One of my interns came up with this, and he was working with an adolescent patient, and he came to me with the app, and it was kind of like well, duh, that was. Because it seems like no matter the SES of the patients, no matter what their cognitive level is, all of them have their smartphones, half of them nicer than mine, and they keep them with them. So it's very logical. So we need an evidence basis to it, but that for me is what's filling in the gap, is using the free apps.
But you both touched on something that's really important. It's really the way to disseminate these programs. We ran into problems with Headstrong many years ago when the first study that came out was comparing it to weightless control, and it came out very, very, very well. It looked really great. Then we did it compared to an attention placebo, and the results were less dramatic. And at that point, the business people that were involved, and there were a number of business people involved, really got discouraged and kind of dropped it. And so it never got widespread dissemination. And the talks were around, okay, if we've got this effective program, how do you sell it? How do you disseminate it? Do you do it through doctors? Do you do it through, do you give it to a drug company like AstraZeneca that does migraine drugs? And you say, hey, we've got this program. You guys can buy the rights to use it, put it on your website for added value or something they call it in business, and you guys can use it. Or do you sell it directly to the public? We have this program that potentially would help your child with migraine headaches. What are all the problems with that? Well, the business people wanted to say it was scientifically proven. Can I say that when the attention placebo trial didn't look as good as a weightless trial? That's the problem. And that's, you know, do we disseminate those things anyway, knowing that some kids are going to be helped and the likelihood of anybody being hurt is very low? Maybe, with the proper disclaimers. Do we release it through our Division 54 or our Division 53 or whoever? It's a real dilemma. And their publishers probably out there would probably see a market for that. I know they do for books with CDs as a supplement to it. But, you know, or, you know, people like Starbride, they get enough money where they can just give them away. They just send them to doctors who give them to their patients. And the way they have it, there's a card the doctor gives to the child with CF, and they send it in, and they send them a free program. So that's the big problem. And that's part of what I want this task force to do. How do you partner with industry, basically? How do you disseminate these things? How do you get them out there? There's concern, you know, we've been talking about putting on the website for Division 54 some empirically validated treatments, the manuals for them. And then some people say, well, if I put that out there, how do I know those people are trained to be able to implement it? You know, they've got this manual, but they don't have any supervision. We've had people contact our mentoring program person, Sharon Berry, and say, I'd really like mentoring and doing cognitive behavior therapy. Well, we're not in the business of teaching cognitive behavior therapy. That's what you learn in graduate school. We can't do that sort of thing. So that's what people have that concern. Who do the manuals get in the hands of? And do they know, do we have some obligation to make sure that they have some minimal training? You know, some people have instruments out there they won't release until the person goes through some kind of training process. And that's probably the way that stuff's got to go, I guess. I don't know for sure. I don't have the answers to that, but you're right, it's a big issue. Any other? I've got it that we have about 20 minutes, and it's not nearly enough to go through this stuff. So we can field questions. I can give you one example of this. Oh, what would you like? You want one example? Okay. No. Losing track of stuff. Okay. Well, let's talk about okay, here's another approach to looking at adherence improvement, and that's theoretically based. If you write a grant anymore, or even if you write a paper anymore about your intervention to improve adherence, you better have a model, a theoretical model. In the old days, what we did is said, well, there's some empirical evidence that this and this and this works, so we're going to try this combination and see if it works. No theory, no nothing like that. Then people started saying, oh, these should be theory-based. So let me give you a couple examples. This is a children's health belief model. It's based on the health belief model, which is the oldest one of the oldest theories out there in preventive medicine and in health behavior change. What they've added to this, in addition, and what's not shown here is cues and barriers. One of the two, particularly barriers, one of the most important variables. And so what they were looking at is demographics and health beliefs and caretakers' motivation for the child, and then they put parent stuff in here, parents' perception of vulnerability and severity, and expected medication use and then use. Anyway, I have a lot of problems with this expected medication use, but I won't say for now. But let's talk about an 8-year-old boy who has moderately persistent asthma, requires daily inhaled anti-inflammatory. The boy has been asked to monitor his peak flow levels once a day, and after he takes his bronchodilator medication, his parents have been asked not to smoke in the house and to take steps to minimize his exposure to other allergens in the home, such as dust and pet dander. Now, my thought was if we had enough time, I'd go say to you guys, okay, but what might you think about? I don't have enough time, so I'll try to tell you. So what are the implications? How about perceived susceptibility and severity? What would you want to do about that? Well, the clinician could assess whether the patient and the parents have accepted his condition and have a realistic view of the severity of his asthma. If they have an unrealistic view, they could review peak flow records and encourage the patient and parents to monitor his symptoms and to gain a more realistic perspective about severity. You know, if the person's saying my child's asthma is not severe, and then you start having them collect data to say, well, look, this looks like they have some pretty severe problem. They're coughing at night, had to use their rescue inhaler a lot. Information about severity should be balanced with positive information, encouragement, and optimism that the parents and the kid can control the disease and adhere better. So that would be susceptibility and severity. That would be the factor you would look at. What if you were looking at perceived benefit? beneficial, particularly in terms of quality of life benefits. If it's low, review the potential benefits of the regimen, such as increased participation in sports and social activities. Clinicians should also be alert to the possibility that prescribed treatment may not be beneficial in spite of optimal adherence. In these instances, the parent and the patient should be encouraged to communicate this information to the doctor and ask for modifications and additions to the regimen to increase efficacy. Perceived barriers. Clinician can interview the parent and patients to identify logistic barriers that prevent them from fully adhering. For example, taking bronchodilator medications as needed requires the patient and the parents to make judgments about need. How do you know when you need an as-needed medicine? Well, they may need assistance in monitoring symptoms and deciding when the bronchodilator medications are required. If you are running and you get out of breath, that may be an obvious one. You should take your bronchodilator. But if your pulmonary function testing results go down after a sports activity, that may be another indicator. Parents may also perceive multiple barriers to reducing their son's exposure to indoor allergens, such as how do you find time to remove pet dander on a regular basis and going outside to smoke. A good general question to ask the patients and parents would be, what gets in the way or prevents you from doing what you need to do? And that may lead to practical recommendations from the clinician, like smoking in a garage during the winter. Cues to action. Clinicians should assess for reliable internal and external cues. Well, what are reliable internal cues that asthma needs to be treated? What's the one main symptom? What? Didn't hear that. Yeah, wheezing or dyspnea, being out of breath. And if those aren't there, then there needs to be some external cues. Let's say the kid's on a preventive medicine regimen, like the inhaled steroids. They may need reminders for that because they're not having the internal cues that are propelling them to do the particular regimen. If they're asymptomatic, they may not be insistent, like I just said. So they might need external prompts, setting a watch, monitoring, prompting adherence, those kind of things. Let's get past self-efficacy. Tell you about one I like better. I don't like that one as much. I got them all in my book, by the way. And I think you have a copy of them, don't you? Yeah. Let's talk about applied behavior analysis or operant conditioning. So people get these things mixed up all of the time. So let's make it easy, folks. Let's talk about when we want to strengthen a behavior. This column right here. So if we want to strengthen, we add something, some stimulus. We call that positive reinforcement. Lay terms, we often talk about payoffs, rewards, positive consequences, tokens, whatever. If we subtract something, and that also results in an increase in behavior, that's called negative reinforcement. And it's called reinforcement for a reason. Skinner called it that because it's the opposite of positive reinforcement. You're doing a different operation. What can you think of, what pill can you think of that would result in relief? Say if you had arthritis, if you took a non-steroidal, right? And you got pain relief, you could say the person is negatively reinforced for taking that pill. So then let's look at decreasing behaviors. We want to decrease behaviors, we add something. Now, we're not recommending spanking. I'm just giving you lay terms that are used for that. Scolding, hurting, spanking are all positive punishment. We also know that these have lots of side effects. They're not very effective. It's much better to look at subtracting something to decrease a behavior like extinction or negative punishment, which means a loss, a fine, a response cost, something like that. It's a much better way to deal with things. But people get these messed up all the time. They call one the other. They talk about, I heard somebody the other day talking about Skinner and Pavlovian conditioning. I went, talk about mixing up two different approaches. So the other part of this, too, is that behaviorists are not just concerned with external cues. contingency, consequences for behavior. Skinner even talked about long ago that people are guided by internal events. And part of that is what they described as rule-governed behavior, or what's now more increasingly being studied as relational frame theory, which the therapy approach of acceptance and commitment therapy came out of. Are people familiar with that? It's a very different approach in behaviorism towards dealing with internal events like emotions and thoughts. So rule-governed behavior, let's just go with that because it's fairly easy to explain. Rules, you know, or proverbs, advice, all that kind of stuff. They're valuable because we learn them without directly experiencing them. And the consequences are implied by other rules. Parents count on these. Look both ways before crossing the street. Whether rules are followed or not depends on a history or punishment for not. Immediate local consequences for following rules, often in the form of social approval or disapproval. Contacting the contingencies in a rule. So if your doctor, if you do follow that rule, you see that that's the case, that also reinforces rule following. Or automatic or self-given consequences, positive or negative feelings or thoughts. 14-year-old boy is diagnosed with polyarticular, meaning more than 4 joints involved. 2 years ago, his disease has been under poor control, as evidenced by multiple active joints, extended joint stiffness in the morning, severe limitations in activities, moderate to severe joint pain reported by the patient. The regimen consists of oral anti-inflammatory medication, naproxen, 2 times a day, range of motion exercise, wearing a splint at night. The referring rheumatologist suspect that non-adherence is contributing to the poor disease control. Patient lives with both parents who work, both of them work outside the home, and he has an older sister. So, focus on the complexity of the regimen, the response cost first. The clinician might discuss with the patient and occupational therapist ways to simplify the regimen. Switch to another anti-inflammatory taken once a day, reduce the number of exercises. Help the patient find reliable cues or prompts for adherence, particularly when the disease is not very severe, monitoring, recording, that kind of thing, daily Pillbox. They need to provide advice about how to reduce aversive consequences for regimens, for example, taking some kind of medication or food like antacids to reduce the gastric irritation with nonsteroidals. Positive consequences for adherence may occur for this patient when he's symptomatic, as adherence results in the release of disease symptoms during relatively asymptomatic periods. May have to program in positive consequences like token system programs. And might also need to include point fines for non-adherence. From a rule-governed perspective, the patient may operate on unrealistic or unhelpful rules about his disease. For example, in a regimen, he might think he needs to be vigilant about following his regimen only when he's symptomatic. The clinician would need to help challenge the utility of this rule and to formulate more helpful rules to advance his health status. I need to take my medicines, do my exercises, wear my splints, even when I feel okay, in order to control my arthritis and to prevent flare-ups. Oh, look at that. Book keeps popping up on us. But that rule-governed behavior, too, part of the thing is sometimes people don't generate rules when they need to. And so that's the other part of it, not just generating faulty rules, but not generating rules at all. You might have to help them do that part. Probably got about 10 minutes. So, some questions?
So you have these theoretical models that, say, the practitioner or a clinician could potentially use to guide how they're going to approach non-adherence or adherence. Is there a way that we would know how to select, which model to start with, or are they all equally effective?
Good question. Depends on who you ask. I think my perspective on this is that there's value in each of these models, that sometimes there's even overlap. There's a little section in my book that talks in that particular chapter about adherence theories, about what can you extract from all of these theories. Are there a number of principles that you can take away from all of these theories that make sense? And there are a list of those that I came up with, and other people may come up with other lists, but I think that's one way to look at it. Take the best out of all. Like for me, the health belief model, the most important component to me is barriers. And it's been very helpful to look at developing barriers to adherence, looking at tailoring regimens to families who have unique barriers, and they vary across families. Some of them have very similar ones. That's very, very helpful. I think perceived severity and things like that could be useful if people are not perceiving their illness as being very significant. I think sometimes when people have more mild symptoms or their asthma is under good control, they tend to minimize that. Or they say, I outgrew my asthma, when most asthma specialists would tell you that nobody outgrows asthma. So those are valuable, I think. I am a behaviorist by training, so obviously applied behavior analysis seems to make a lot of sense to me. But I've also been more cognitive as the years have gone by. So some of the cognitive behavioral theories, and particularly looking with older kids, young adults, the way they think about things, the way they think about their disease and their regimen can really influence how they behave towards their regimens and whether they're adherent or not, or how they manage it. So I think those cognitive factors become more important. Self-efficacy kind of gets at, I have a little more problem with self-efficacy, probably more than any of them, because when people talk about, well, we need to promote self-efficacy, if you think about what Bandura says promotes self-efficacy, for example, inactive mastery is one of the main ways. Well, what does that mean? Practice in successful experiences. And then he has other things like vicarious learning, which is true. People can learn from other people. Modeling, important influences. That's been around for a long time. The problem is that, when people say, well, what you have to do is you have to enhance efficacy, and then that enhances adherence, they don't often measure that way. They'll measure efficacy at baseline and then post-treatment along with adherence and say they both changed. But you can't say that was a mediator of that change. They concurrently changed, possibly. We don't know. We didn't measure it all along. You probably could do that. You could probably say we're measuring self-efficacy, and all of a sudden, after efficacy, you got to a certain point, boy, adherence shot up. That'd be a little more convincing, I think. But some of the theories I have, like some of them that talk about, like the theory of reason, action, plan, behavior, talk about intentions. I have problems with intentions. If I come home and my wife says, I intend to cook you dinner tonight, and she does, because she's very nice to me, and she doesn't, I don't give a hoot about her intentions, right? The road to you-know-what is paved with them, right? Well, Dad, your kids say that. Dad, I intend to clean my room before I leave for practice, soccer practice. I don't care about your intentions. I care about your behavior. Did you do it? Is there a correlation between attitude and behavior? Weak. Everybody's shaking their head yes, but they're very weak. They're very weak.
But I was just thinking that I feel like one of the things that is missing from a lot of our adherence models involves the cultural piece, the cultural aspect of, from all different levels, like from our perspectives as providers, from family members, all the way from how Latino parents perceive stimulant medication for ADHD and whether they choose to do it, to how our physicians manage the pain of our sickle cell disease patients, or our nurses manage the pain of our sickle cell disease patients, because they may or may not think they're seeking medication. So I feel like it's missing, from the models, and it's something we have to struggle with every day.
I totally agree with you, and I think the closest we come to that is we talked about when we talk about social, the could be cultural. Find out a lot of our Hispanic families have a lot of ideas about cures and things that you take and remedy. Then they don't talk to people about their own cultural kind of remedies that they use that we need to know about. And I think that's very important, and if they're buying into it. And does it violate somehow their cultural view of things? And I agree with you. I think there's a lot that needs to be done in that area. And these theories need to be updated, or maybe possibly even new ones looked at.
So in that sense, I do think that attitude and behavior are closely.
Well, even looking at some of the studies that look at the difference between African American children and Caucasian children or other children, that African American kids have lower rates of adherence to all kinds of things. It doesn't say anything. To me, it just, okay, so why is that, What's the difference there? It's a difference that we need to explore, but it doesn't mean it's a deficit. It means there's some reason why that's occurring in that community. That could be a lot of reasons. One of the reasons I mentioned was the access to appropriate care. Why don't more African American kids eat better food? Well, go to their neighborhoods. You see any fresh markets? I'm so pleased that right down from KU Medical Center where I work, in the Hispanic community area, they have an open market now where the local farmers there are bringing their foods, and they're starting to do that to get healthier foods in those areas. That's why a lot of those kids don't eat healthy foods. They don't have access to that stuff. So I agree with you. Instead of saying there's a difference, we know there's a difference. We have to say what are the factors and what is it in the culture that would explain the differences. But you're right, they're missing. The closest to it is social norms. But that's even sort of vaguely related. Very good point. Yes?
In practice, how do you deal with, we talked a lot about educating parents on ways to get their kids to adhere, and discipline strategies, like discipline. And how do you, in my limited experience, when we talk about, when I'm introducing the concept of an intervention designed to help kids do better in school or whatnot, clearly you probably sense maybe a little bit of defensiveness from the parent because there's an implicit message that they're not doing something right sometimes in some of these messages. So in practice, how have you learned to go about that or to deal with that? I get nervous because I sense it from the parent, and I try to gloss over the details of what we're asking them to participate in, and just try to get them to sign the consent form. So
you're not fully informing them, eh? That's one way around it. Don't tell them what you're doing. I wouldn't.
I try to put it in I try to reframe it.
I know what you're talking about, but it comes up clinically. I mean, I had a mother the other day was telling me. She said, well, I should have brought him to you when he was 3 years old because he was showing these oppositional behaviors then, and he's 7. He's harder to control. And I said, you know what? Yes, it would have been better, but you didn't. For whatever reason, you didn't. And you are here now, and a lot of parents wouldn't even be here now. So I want you to give yourself some credit for being here. And we're going to do everything we can to help you develop some strategies, and some of which you probably already know on your own, that I'm just going to reinforce and say, hey, you got a good idea here. So making it okay to look at new approaches. We're not saying that you haven't tried to help your child read. You probably have spent a lot of time doing that. But we hope that we have some new ideas that might help you do what you want to do and what you want for your child. We know what you want this for your child. That's why you're talking to me. You wouldn't be talking to me if you didn't want something better for your child. And we think maybe there's some things we can give you that would help. I just think parents feel so good or low self-esteem or feel like that they have failed. You know, they feel bad about that. They come in with their tails between their legs and that. Yes, ma'am.
I think one of the things is that in the context of, consult liaison kind of work for adherence in hospital settings, for life-saving medications, or, so close to life-saving where it's like really poor quality of life to really better quality of life, and this is really, this is crystal clear. If your kid is having an asthma attack, give them the inhaler or try to prevent that. How do you think it differs, especially with respect to psychiatry, where there is a little bit more of a judgment call, and the parents can say to you, hey, my kid isn't going to die if we miss this dose. What is your patient education, what's your approach there?
I would be making a guess about this because I don't work in this area. I mean, I work in the area of mental health, but I tell parents I don't do drugs, so you have to talk to people about drugs that do drugs, meaning you're a pediatrician or I'm not trying to back out of answering. I'm going to answer your question. But I'd say you're right. You're absolutely right. If you give this ADHD medication, your kid's not going to die. But if you don't give it, what else might happen? Because there are other things, not necessarily worse than dying, but there are other things that are pretty bad, like failing school, like being put back, like kids teasing you because you can't read very well, or being aggravated because you won't keep your hands off of them, and they won't play with you, and nobody likes me. And when your child comes home and says, nobody likes me, people hate me, that's painful to hear that from your child. Now, he's not going to die. You're right. But see, I always try to find a way to agree with people. I always try to find, in any kind of debate that we're having, my brother and I had this big debate about Obamacare. So I says to him, answer me one thing. Do you believe that people should not be penalized for pre-existing conditions? And he said yes. So my brother, who I love, we came to an agreement about something after arguing for a good 15, 20 minutes about socialism, and my side was socialism, by the way. But there's always an area, some people, I don't know if you've read The Righteous Mind. It's a wonderful book about how people think differently, the left and the right think differently, and they have different basis for their decision, moral basis. And it opened my eyes to again look at, there's always something that you can agree about with what people are saying. When parents say things like, there's always a way of saying, you're right, he won't die. Think about what would happen if he didn't take this course. And there's no pressure for you to do it right this minute. So think about it for a while, or talk to other parents. But it's a little easier for me because I don't have any dog in that fight. I'm not prescribing medicine, right? But I feel the same way about behavioral interventions. If they say, "Oh, I've tried that," okay, well, all right. That's okay. There are other ways of doing it. Done? Thank you all.